Ladies and gentlemen, we're about to begin our afternoon together. My name is Patricia Simmons, and I'm a physician and executive at Mayo Clinic, and it is my pleasure personally to welcome you to our campus today, and a real privilege to host you on behalf of Mayo Clinic. I have the great misfortune of not living here and working at Mayo Clinic here in Florida. I hail from Minnesota. And I must say, I must have picked a beautiful week to be here. It's over 100 in Minnesota, humid as heck, so I'm just saying to everybody, I'll see you someday. Today, you will launch a conversation in this state that is so very important, not only for the health of Floridians and the quality of medical care in Florida, but really for the people of the United States. And that's why we're deeply grateful for your taking the time and having this interest. We have tools today in telemedicine that will make health better tomorrow, and in fact could be making health and healthcare better today. So this is an important and timely conversation. We're very pleased today to have as our hosts for the event two illustrious members of the Florida Legislature, and I really want to welcome not only Representative Jones and Representative Pigman, but all of our government officials who were so kind to take time out of their day and to take an interest in this important subject. So I'll ask my Mayo Clinic colleagues and perhaps other of you who are here as well to give a hand to our elected representatives and senators. And now it's my pleasure to welcome our hosts to the podium to let them take over today's meeting. Representative Jones, would you join me up here, please? Thank you so much.
Good afternoon. Good afternoon. All right. Now, I know we've got an exciting topic here, but y'all got to wake up. All right, the trip wasn't that long, but we're just really excited to have you here to the 2013-2014 Florida Telemedicine Public Policy Symposium. First, I'd like to take this opportunity to thank Mayo Clinic for having us and hosting us today. I have been on this trip for about 3 years, and Mayo Clinic has been right there by my side, helping to push me, pulling me, as we've gone through this journey. And so I felt it was only fitting that we have the opportunity to see telemedicine and telehealth in action right here in Jacksonville at Mayo Clinic. So please join me in giving them a round of applause. Today I also have the pleasure of being able to co-host this event with my colleague and a great statesman in and of himself. Although he's a freshman, he hit the ground running during this last session, and we hit it off. And so today you will hear from Representative Pigman, a man who understands telemedicine, a man who recognizes the importance of it, and one who I am just truly, truly pleased to be able to work with. Let's give him a round of applause. We have a busy schedule over the next 2 hours for you, but before I give you the complete rundown of the event, I'd like to tell you why it was so important for us to gather today. We wanted to host this symposium to share what we've learned about telemedicine, because we realize that the present and the future of healthcare is moving toward telehealth and telemedicine. Telemedicine and telehealth are innovative forms of healthcare delivery, which are powered by transformative technology and high-speed broadband. All over the country and the world, telemedicine has been touted as a cost savings, convenient, and time-saving healthcare delivery option. We believe that by allowing private insurers, as well as Medicaid, to extend coverage for telemedicine services and to reimburse for these services that we will definitely take our state to the next level. And this will be a significant impact as we move forward. Every year, Florida spends a great deal, billions of dollars, on health care. On average, Florida's Medicaid program covers less than 16% of the state's population, but 98% of our budget is spent on health care, and more than $17 billion, that's with a B, dollars, to treat acute and chronic preventable health conditions. Hear what I say: acute, chronic, and preventable health conditions. Additionally, as of 2006, Florida wastes more than $1.1 billion annually in avoidable emergency room care. In Texas, Georgia, Oregon, and 15 other states across the nation, telemedicine policy that allows private insurance and state-funded health services has driven down health costs significantly. Additionally, more people typically residing in rural areas have had increased access to quality and affordable health care, treatment, as well as access to several specialists that they otherwise would not have had access to. We hope by the end of this program you'll understand why we believe enacting a policy that would give Floridians the right to choose a cost-effective, hassle-free, and patient-centered health care delivery option is the right way for Florida to go. We also hope that you be willing to support a policy that would allow private insurers and Medicaid to extend their coverages for telemedicine services and reimbursement so that we can significantly drive down these costs. To educate us further about telemedicine, we have several industry experts, practitioners that will come to help to share with us what they deal with on a day-to-day basis, the reality of the positive impact of telemedicine and telehealth. We will begin with a brief overview of telemedicine. Then we will learn about the various specialties within telehealth and telemedicine. Then we'll hear from the perspective of the insurance, healthcare, as well as the broadband service providers. We know that none of these things are possible without all of us working together, and so we have representatives from each of those industries here with us today. We'll also learn about the recently enacted telemedicine legislation that has taken place across the country. We will conclude with a must-see demonstration of telemedicine right here at Mayo Clinic. And I know everybody's excited about that because I waited to see it with you, so I'm going to be, on pins and needles throughout the entire presentation. Now I'd like to take this opportunity to bring forward my colleague, Representative Pigman. Let's give him a hand.
Thank you for setting our symposium's foundation, Representative Jones, and the military person prefers to refer to as Madam Leader Jones, correct term. I'd also like to thank everyone who's joined us both in person and online, on live stream. I'm sure we're going to learn a lot today, and like you all, I'm here to listen and learn. As a country doc, I'm already sold on this concept being a critical component in how we deliver care. And it's not just in the country, it's not just rural, it's really going to be important everywhere. In case you have any questions during today's symposium, there's 2 specified question and answer sessions. You can write them down. And if you're joining us online, please feel free to submit your question to the following address. It's smith.lane@mayo.edu, and that's smith.layne@mayo.edu. To start things off, we're going to have a brief presentation about what telemedicine is and what it encompasses. And to guide us through that process, we have Gary Capistrant. Gary is the Senior Director of Public Policy at the American Telemedicine Association, which is the leading international resource and advocate promoting the use of advanced remote medical technologies. Gary's expertise in health policy is based on over 30 years of experience with Medicare, Medicaid, and national health reforms, which of course sounds like a terrible ordeal to go through, but God bless you. His knowledge of health policy has led him to become a trusted advisor to associations, innovative health providers, and investors. And he's here today to deliver the first of two presentations that he will give the presentation. So please join me in welcoming Gary Capistrand.
Thank you. I appreciate the opportunity to be here with you and with so many good state legislators that are interested in this. From that introduction, you can probably tell I love talking to legislators, federal, state, about the needs for telehealth and the opportunities that there are. So great opportunities for Florida. But let me lay the groundwork, and then we're going to have some people that actually know what they're talking about give examples about the specific uses. But because telehealth itself can kind of be a foreboding subject and kind of intimidating. But it's really pretty simple. A couple major forms. One is video conferencing. How many people use Facebook or Skype or anything else to talk to grandchildren or other family members, or in a work setting, teleconferencing to some other site? Well, that's the major use of telehealth, is video conferencing. It's just that simple. Another is what we call store and forward, or asynchronous. That's like sending an email with a photo attachment. How many people have done that? Yeah, a lot more hands. How many people have done remote monitoring, or monitoring themselves? You're out running or at the gym and you're checking your heartbeat. You may be at home. You figure that I've got a little atrial fibrillation that sometimes goes on, and I can feel my heart flopping around and think, I better pay attention to this. That's remote monitoring. Those are the three major uses of telehealth. There are other aspects. To us, telehealth just means the delivery of healthcare services using technology. It's just that simple. It's not about the health records. Obviously, there is a role for the use of the health records in the telehealth world, big generators of digital data and big users of digital data. But it's about the delivery of healthcare services. Sometimes the lines get kind of blurry when you get into call centers and emergency response systems and things like that. But we try and be a big tent and take in all of those uses if it's all about the delivery of healthcare services. The single major use of telehealth is in radiology. About half of the visits of radiology. You go to a hospital, particularly at night, and need a CAT scan read, something like that. You don't know where that radiologist is. They may not be in the building. It may be elsewhere, and you don't really care, and you don't know. You just want it to go to somebody that is recognized and can deal with, on a specialty basis, what it is that you have. So that is the biggest single use. A lot of times telehealth too is used for one-time situations. It's an emergency. Or it may be very ordinary. You have a skin rash and you want to determine how important it is that you see a dermatologist. Because you don't know a dermatologist, but it's going to take 4, 6, 8 weeks to get to a dermatologist if you don't have one established. So there are all kinds of very common uses for it. It is not a healthcare service. It's a way of delivering a service. I just got an email this morning. Somebody that's into health spending accounts wants to know, where's the IRS regulation that says telehealth is covered? Well, there isn't such a thing, because telehealth is a way of delivering a service. If it's going to a doctor, yes, that's clearly something that you can use your health spending account on. If it is doing something else, it may get into areas outside of healthcare, but it is just healthcare. And at some point, maybe 10 years from now, we won't be talking about telehealth, telemedicine, or all of the other terms that are used for it. And that's the other part that's confusing to people, is the range of terminology. mHealth, e-care, remote visits, technology enabled. It's like everybody has to have a different word for what is basically the same thing. And then we have this issue of we want to be the same as in-person. The CPT codes are the same as for in-person services. The billing procedures are the same. The regulations should be the same. Yes, there are differences with the in-person, and there are times that there are some unique things that telehealth is better than in-person, and that there are things that in-person obviously sometimes has to happen. But from a standpoint of public policy, as much as possible, it should be the same. Other uses that are very common are correctional health care. That's how many states get into the whole area of telehealth. It's very expensive to take a prisoner to the doctor. It's much, much cheaper to bring the doctor to the patient. And so ways to deal with that. But then the other major uses probably, or the most common, most developed, is with stroke. If you think you're having a stroke, it's important that it be diagnosed by a stroke specialist so they can start clot-busting therapy, and you may be able to walk out of the hospital avoiding death and disability because of the use of that clot-busting drug. Every hospital in the country should have a setup so that within 1 hour of hitting that hospital door, you're diagnosed. And there are lots of ways to deal with that. Yes, you can deal with in-person staff, but sometimes it's nighttime, they're busy, that there is a need and an opportunity to use telecommunications as a way to deal with those situations. Last year, about 100,000 people had their stroke diagnosed remotely and have much better outcomes. Another very emerging area is in mental health. Sometimes that distance, that being removed from the provider, the psychiatrist, the psychologist, social worker, is therapeutic by itself. And certainly there are conditions in which it's difficult to think in terms of the patient going out of their home to the doctor. You've got severe depression. The last thing you're going to want to do is go out into the community, whether it's even in your car or some other way, to get frequently to that provider. So that is a very good use of telehealth. Most of mental health is talking back and forth. And so to use telehealth to do away with the problems of distance and time is a great use of it. Some emerging uses are for home care. Right now, most of the telehealth coverage requires the person to be at some kind of medical establishment, a hospital, a doctor's office, a clinic. But those same services can be provided directly into the home. And certainly there are situations in which the patient can't leave the home because of their physical condition, because of a disability, some other circumstance that prevents them from doing that. There are some emerging uses for in the home of like home dialysis. Medicare covers about 95% of the cost of kidney dialysis. They'll cover it in the facility. They'll cover the physician connection into the facility, but they won't cover it for doing home dialysis. There are opportunities to get people being dialyzed at home, and the video connection with a nephrologist once a month, whatever the requirements are, to be able to maintain that person at home in a less costly way. One of the things we tend to focus on a lot about the technology And it's always important to remember it's not the technology. The telehealth is a way to address and solve many of the problems of the healthcare system. Physician shortages, long waits at the emergency room, hospital readmissions, declining physician productivity. Physicians are about the only, and other healthcare workers, in the area where productivity is declining. We expect a lot more. We lay on things like medical records and other mechanisms. Telehealth is a way to increase that productivity. If Florida decided that you wanted to increase your physician supply by 10%, there is very little that you could do that would result in that 10% increase. I know you've been good about creating medical schools everywhere, but there's a certain capacity limit to that. Telehealth is one of those things that is that force multiplier that can allow for that time to be used much better. Other problems with the healthcare system, hospital readmissions. You have the person with congestive heart failure that you need to monitor. Medicare will ding the hospital for having a high admission rate. A whole lot of hospitals have woken up to telehealth because of that Medicare payment penalty that's in place, and some ways to deal with that. A lot of our goal in terms of public policy is to remove barriers, and I say this particularly to the legislators that are here. We're not looking for more money. We're just looking for those barriers that are in state law, state regulation, medical board rules, and removing those that are artificial. We have this artificial distinction between rural and urban, between synchronous and asynchronous, between being in a physician's office and being at home. We would all be much better off if we did away with those kind of barriers that don't have a clinical basis, and we just treated people, treated providers intelligently in terms of what makes sense for what they're doing. Now, a lot of this ends up meaning reimbursement changes to get away from the fee-for-service reimbursement to move toward those kind of systems that are value-oriented, like medical homes being paid on a monthly basis, like accountable care organizations, like other kinds of managed care there, and particularly in those forms to be able to use telehealth as one of the tools that's available to be able to stay within those parameters. Certainly, Medicare policy is a very important one and critical in this state, and Medicare is one of the worst payers of telehealth in the country. Fortunately, most Medicaid plans throughout the country are better than Medicare. The biggest single user of telehealth in the country is the VA, Veterans Affairs, and there's a lot that we can learn from what they've done in a lot of other states. Medicaid in most states covers something about telehealth. Now that something varies widely from states that have complete parity, like Mississippi enacted it this year, and Vermont have legislated parity with that telehealth in their Medicaid plans has to be treated just like in-person services. So Medicaid is an important one to build on. The other is private sector and the state's role in regulating health insurance plans and the kind of standard in there. I'll talk more about that later on when I'm up here. So the importance of these things coming together is a critical one, and it's great to have so many people interested in various aspects that are here today, who are interested in developing for Florida what Florida needs, but to take advantage of the expertise, the lessons learned from around the country, that in almost every case, they're doing it better somewhere else than unfortunately what is here. So there's a lot that Florida can learn on and avoid the problems that other states have had, and moving forward with that kind of legislative effort. I learned that the medical board is taking a look at, on September 9th, taking a look at the whole role of telehealth, and medical boards are an important component here. Again, our view is that telehealth should be treated just like the in-person services, that there shouldn't be additional requirements, like that the patient has a prior relationship with that doctor. Again, a lot of telehealth is a one-time deal. That radiologist, that neurologist that's diagnosing the stroke. It's not a matter of prior relationships, but we do have some states that have tried to put in those kind of barriers. There's a lot that the medical boards can do to make it easier for doctors to talk to doctors without that triggering a license requirement. A doctor should be able to talk to a doctor anywhere in the country without the triggering of the license issue. That's an important thing to go on. So there's a lot that we can talk about. Like I say, my colleagues are going to end up providing some very good, very specific examples of what telehealth can be used. When they're doing that, please think about how can we do this for 10 times or 100 times the number of people? How can we do this for statewide in Florida? You got 19 million people that need these services. What are the barriers to getting telehealth into those homes of the 19 million people so Florida can have the best of what healthcare offers today?
Thank you. Thank you for that informative introduction to the world of telemedicine. I'd like to go off script for just about 20 seconds because it's important that you understand 3 examples which have been personal to me so you can get a feel for what this is. About 4 years ago, I found myself in a very hostile environment, a very austere environment, and for the medical people in the room, I was the only one there who wasn't a surgeon. So I was acting as an internist emergency medicine physician. And it was at least 24 hours and more like 48 hours before anyone who was ill or injured could make their way to Germany. And at that time, I had a patient who had what turned out to be Q fever, quite seriously ill with it, with pneumonia and hepatitis. That's caused by Coxiella burnetii, not something we see in the United States very much. Due to the unique environment there, I was able not only to communicate with an infectious disease specialist, but I actually ultimately got to the person who does research on Q fever. That individual, that soldier, was treated, was diagnosed. Even though we couldn't do the testing, the blood was obtained, and the patient was starting to do better by the time he got on the plane and left for Germany and had full recovery in the United States. I don't know that we could have accomplished that prior to the kind of communication, this collaborative relationship with other specialists, this physician-to-physician communication that we're talking about. And that physician, that specialist I talked to happened to be in Ohio. Go back about 3 years ago, and in my emergency department in Highlands County, Florida, rural emergency department, my brother-in-law's father presented with stroke. We have one neurologist. We don't expect him to be on 24/7. We used a telemedicine source to consult with a neurologist. And my brother-in-law is an attorney, and his father is a retired Air Force colonel. Pretty critical judges of people. And by the time that interaction was done, they had a wonderful relationship with the neurologist. It was as though he was in the room. It was a fantastic interaction, and even though it was after hours, appropriate care was provided. And then just very recently, just a couple of days ago, if it was after hours where I happened to be in Kuwait, my x-rays, my CT scans were read by a radiology resident in California. So we're already doing this to a certain degree. And I loved your term force multiplier. That is the best way to think of it. How you take one force of soldiers and with a slight increase, you double or treble their strength. So we've got this basic understanding. And let's get up close and talk to some people who are specifically involved with it throughout Florida. And when this session is done, there'll be a question and answer period, so save up your questions till then. Our first speaker in this segment will be Dr. Ann Burdick of the University of Miami's Miller School of Medicine. Dr. Burdick is the Associate Dean for Telehealth and Clinical Outreach and Professor of Dermatology at the University of Miami. She has nearly 16 years of experience in telehealth and has presented and published extensively on telehealth and teledermatology. Next, then, we'll hear from Dr. Kim Landry. Dr. Landry is the president and CEO of Excalibur Telemedicine Services. He's a board-certified emergency physician, who has more than 24 years of experience working in emergency departments and over 17 years experience working in EMS medical director for multiple EMS and fire rescue agencies. He's also an associate professor of clinical medicine at the FSU College of Medicine in Pensacola. Then we'll hear from Dr. Torre Malasanos. Dr. Malasanos is the director of the Florida Initiative in Telehealth and Education at the University of Florida. She also continues to merge her interest in technology and childhood obesity through the ongoing development of Virtual Me, an interactive individualized lifestyle modification program for children to be incorporated into the primary care provider's treatment of childhood obesity, an absolute critical endeavor. We'll also have a presentation from Dr. Peter Pappas. Dr. Pappas is a trauma and acute care surgeon with the Trauma Center of Health First, Holmes Regional Medical Center in Melbourne, Florida, and an assistant professor at the University of Central Florida College of Medicine. Dr. Pappas has led trauma telemedicine at Health First since 2008. He is also the coordinator of SparrowNet, a joint telemedicine initiative of the Florida Department of Health and Florida Committee of Trauma that links the state's trauma centers together for disaster response and preparedness. He is actively involved in developing telemedicine on the Space Coast, including applications for first responders, critical care, psychiatry, and neurology. And lastly, we'll hear from Jeff Waxman. Jeff Waxman is the practice operations director for Mobile Physician Services, which is a business he operates in partnership with his father, Dr. Richard Waxman. Jeff plays a critical role in continually developing relationships, programs, and unique delivery models with healthcare organizations, commercial insurance providers, senior living communities to improve patient care and clinical outcomes, and to reduce healthcare costs and decrease total spending for high-utilized members. So, Dr. Burdick, if you'll begin, and the others will follow as you complete.
Thank you. Happy to be here today. First, can you hear me in the back? No. Okay. Now you should be able to, yes? Great. Okay. I've been practicing dermatology for 30 years, and for the past 20 years, I've been using telemedicine technology to deliver care to individuals in the state, around the country, and around the world. In 2007, I was active in leading the development of practice guidelines for teledermatology through the American Telemedicine Association, working closely with the American Academy of Dermatology. I was chair of both the task force for those organizations, and that got endorsed by both places. Studies of teledermatology show that teledermatology is accurate for diagnosing and for treating skin diseases. And I have had that experience of teledermatology as being effective firsthand in the over 3,000 patients that I've treated over the past few years. I use different modalities, as Gary was describing. So I use video conferencing to deliver telemedicine to pediatric populations. The Department of Health, Children's Medical Services, the Safety Net program for kids, and I see patients through video where a nurse presents the patient or an MA to me in West Palm Beach, Fort Pierce, and Fort Lauderdale. And there is no reimbursement in the state, as you know, except there is a Medicaid waiver for Children's Medical Services, and through that, I get reimbursed for my dermatology services, and we also have University of Miami professors in endocrinology, genetics, neurology, and nutrition giving care. I also see children on the University of Miami mobile van that travels throughout South Florida to Homestead, Sweetwater, Hialeah, Little Haiti, and for that, again, no reimbursement, so we have a grant through Verizon Foundation to fund that, those services. Video conferencing works well when in conjunction to the real-time interaction, there's also digital photos and history that are sent before going live, and that's what we call the hybrid model. We use that in 8 public schools in Miami-Dade County. That is an innovative telehealth school program which we have gotten support for through several charities and being awarded one of the 30 Centers for Medicare Services Innovations Grant. There were 700 applications, 30 came through. One was for telehealth. University of Miami School Initiative was the awardee there. In May of this past year, I was presented with a child who had a history of eczema, and this eczema was really pretty bad looking at it. And what was most striking was on her face. Eyes were swollen, all sorts of lesions around her face, and it was classic for me for widespread herpes simplex infection on top of a severe eczema, and for that, that child was admitted immediately to Jackson to get intravenous antibiotics, antiviral medications, was in the hospital 3 days. Big change in her care. If she had gone through the regular route, it would have taken a while to get to Jackson, and she would have gotten quite ill, and perhaps her eyes would have been involved. We also use store and forward telemedicine, and that probably for dermatology is the most frequently used kind of care. That is when the primary care doctor sends photographs and history to the dermatologist, and at a later time in an asynchronous mode, that dermatologist will evaluate the information and send a consult back. There are 3 contracts that we currently have to care for individuals. I evaluate crew on Royal Caribbean Cruise Line and Carnival Cruise Line ships that are traveling around the world. 95 of those cases can be seen and evaluated well just by my interacting with them with the digital images. And that includes someone I saw 2 weeks ago, 36-year-old woman with varicella chickenpox, hundreds of lesions on the body, and we managed her in co-management with the medical staff on the ship. There are rare times that the patient has to be referred for inpatient care, and that was for a 63-year-old man about a month ago. Severe drug reaction, and for that I was worried he was going to get extensive sloughing of the skin based on prior history, and we worked with the medical team so that till he got medical evacuation, he was stable and he did well. We also have contracts with for Native Americans through the Indian Health Services in many states on the East Coast, and I now see patients from South Carolina, Maine, and New York to give care to them in this asynchronous mode. I saw a child last year, 2-year-old, and itchy bumps on the palms and soles. Itchy bumps, not a real classic presentation for a PCP, but to a dermatologist, we know that that's a presentation of scabies, just classic for pediatrics, and I was able to write my consultation back and actually call on the phone and tell the case manager there, kid needs to be treated and so does the family so he doesn't spread it. It was a Friday afternoon, 3 o'clock. The benefits for teledermatology. It enhances access to dermatologists who, as you know, are scarce in rural Florida and scarce in underserved urban areas as well. And to enhance this care while maintaining the patient in the medical home, coordinated care by the primary care doctor who works as quarterback to coordinate that care. And while also educating the primary care doc about this particular case and future cases who'll present in a similar manner. Early diagnosis and detection of skin conditions can happen this manner, including melanoma and other skin cancers, which are, as you know, an increasingly significant health issue for Floridians living in our sunshine state of Florida. In summary, teledermatology is the delivery of dermatology care where and when it's needed. Teledermatology is effective, it's efficient. Teledermatology should be reimbursed. Thank you.
Good afternoon. I'm Kim Landry, Dr. Kim Landry, and I am a practicing emergency physician and medical director for a number of EMS and fire rescue services. And I want to thank Representative Jones and Representative Pigman for inviting me to speak to you today on the topic of telemedicine. My interest in telemedicine stems from a need that I saw in a program that I put together that allows for us to deliver emergency physicians to patients in their home through an EMS agency, which would allow the physician to assess and evaluate the patient, and in many cases treat the patient sight on scene, and 8 out of 10 times the patient will not require transport to the hospital. So it's made life a lot easy for many sick patients. My objective today, however, is to impress upon you the value of telemedicine and to emphasize the importance of moving forward in the state of Florida with the concept of telemedicine. I think to have a full appreciation of telemedicine, it's important to put it in perspective as it relates to the practice of medicine. One of the basic building blocks in the foundation of the medical practice revolves around the relationship between the physician and the patient. Everything else in medicine supports that relationship. Everything. So what is telemedicine, and what is telemedicine, and how does it support healthcare? Well, you'll hear two terms talked about frequently, telehealth and telemedicine. And telehealth is the delivery of health-related services using telecommunications and related technology in support of patient care, health education, and a lot of administrative services. Telemedicine is a subset of telehealth, and it focuses more on the clinical services, the direct relationship between the physician and the patient, or between clinicians themselves. So how does telemedicine help in the practice of medicine? Well, telemedicine can bridge the gap between the patient providers, the healthcare providers, and the patients, which would allow for more patients in more locations to receive quality, cost-effective health care. So think of it this way. Telemedicine is to healthcare as a smartphone is to communications. Now, if you stop and think about what a smartphone has done to enhance our ability to communicate between ourselves and virtually around the world, telehealth has that same potential to the practice of medicine. We just have yet to release the full potential of what telehealth and telemedicine can do for the practice of medicine. But it really is kind of related to how a smartphone has enhanced our ability to communicate with each other. So how can we deliver quality health care through telemedicine? Basically, we've already heard about the three categories of how health information is gathered from the patient and provided to the practitioner for decisions to be made. And those include the store and forward, the remote monitoring, and the real-time conferencing. And basically, there are approximately 6 models of telehealth that are available that involve the physician and the patient in different locations, and may also include physician extenders, including nurse practitioners, physician assistants, nurses, paramedics, any medical personnel that can assist the physician at the patient's side to perform their duties. So the top 2 models that I have here are about as close to a face-to-face encounter as you can have. It involves a remote physician making contact with the patient and actually performing an exam on a patient through a healthcare surrogate, or a medical specialist in conjunction with a physician at a patient bedside conducting an exam on a patient. So these first two models are sort of the cream of the crop of telehealth and telemedicine, where you really can't get any closer to a face-to-face evaluation than these two models. And then you have a model where you can do a face-to-face conference and discussion with your doctor, and this would be sort of on the other spectrum, other end of the spectrum of all the telemedicine programs that would be available. And then you have three other models that entail the use of remote monitoring, home monitoring, where data from the patient, healthcare data, is processed in some center, the patient's records are upgraded, and physicians can make decisions on that patient's healthcare based on this system and this setup. And this allows for patients to have their healthcare. You maximize the care you provide while in their home setting, and they don't really need to hopefully be taken to the hospital as often. And then you've got a setup where it's a call center where patients can call into a center, and a nurse call or some person can direct them where to go. So this is basically an example of the model that I developed that uses an office-based group of emergency physicians that can reach a number of patients over a large geographic area through various EMS services. And so a large number of these patients can be treated sight on scene by the physician and then referred to primary care clinics, medical specialists, local clinics, and a host of other areas. And this is basically, again, a face-to-face encounter with the patient where a paramedic from the ambulance service does the exam for the practitioner. So what is the goal of telemedicine? It's to deliver high-quality health care to more patients in more locations. It's to increase access to that care. It improves the overall health and the quality of life to the patients that we serve. And it's going to drive down the cost of the health care across the continuum. So how do we move forward? There are basically a couple of issues that we have to deal with, and they're the two big R's: regulations and reimbursement. And this is at multiple levels. At the federal government level, the American Telemedical Association has been very instrumental working with a lot of these federal agencies and moving the agenda of telemedicine forward nationwide. At the state legislator level, currently there are about 21 states that have passed legislation in support of telemedicine, and we would sure like Florida to join the ranks of these 21 states. The state medical boards, they are getting ready, and they are going to be responsible for the regulation and of the practice of telemedicine. And what I would hope is that the Board of Medicine understands the different models available and not lump everything under one lump sum and declare that to be telemedicine. You really have to look at the different models that we have available, and especially the ones that really are as close to a face-to-face encounter as possible. And then the insurance companies, you know, the healthcare savings that they will have should be very favorable to them. They might even start offering telemedicine policy options to their customers. And the healthcare providers, we have to work together to unleash the full potential of what telemedicine can do to our patients and to provide healthcare to patients. So, in conclusion, I'd just like to thank you for inviting us to speak here. But telemedicine and telehealth is an excellent way of delivering quality health care to more patients in more locations in a setting of fewer resources and fewer health care dollars. Thank you very much.
So I wanted to talk to you about our specific example of telemedicine. I've been involved in this since its onset when we had a request for proposals from Children's Medical Services in Florida. And our answer to that was a three-part approach to telemedicine at the University of Florida with the Department of Health. One was to provide clinical care with teleconferencing. The second was to improve diabetes knowledge and the method of teaching that knowledge to the families. And third was to provide psychological care to teens with multiple diabetes-related admissions to the hospital. So our problem was, just like many other pediatric endocrinologists, we're gathered in academic centers or in big cities, and that's not where our patients are. Our patients are all over the state. And we had a remote clinic in Daytona, so we served Volusia and Flagler County. And we used to go there. We'd get up at 4 o'clock in the morning and we'd travel to the clinic, and we would try to see them all at one time. We'd go there once every 3 months. So you can imagine what that clinic was like. Try this dose, good luck with it, and we'll see you in 3 months. And of course, they would miss the next appointment, so it'd be 6 months before we saw them again. And they didn't know who to call. So as a result, instead of calling us, they would end up in the emergency room. And a child with diabetes in the emergency room ends up a child in the intensive care unit with diabetes. So we wanted to change that. We wanted to provide better care, more accessible care to those children in our remote clinic. We wanted to improve the use of telephone support, and we wanted to decrease the amount of utilization of the emergency care system. So we're doing teleconferencing, and the children come to the clinic. Because of one of the barriers of telemedicine that you've already heard about, we see them all in person at first. And so any new patient needs to come to Gainesville to be evaluated at the first visit. But after that, then they come only to the Daytona clinic, so it's a much more local event for their clinic visit. So the children are evaluated and they get their blood tests done, and then all the information is transmitted to me in Gainesville, and then we have a consultation by teleconference. So there was a shift, There was a shift in patient care. Before that, we used to, like I said, travel to the clinic. We had minimal contact between visits, and the interval was often up to 6 months before we would see the child. So that didn't even meet the standard of care. And since we started the Florida Initiative in Telehealth and Education, which is FIGHT, we have weekly telemedicine clinics, and the contact has improved with these patients. The nurses now know these patients much better in the local clinic, and they know how to reach us whenever they need us 24/7. So the results of that is that we decrease the interval between visits from 149 to 89. So now we're meeting the standard of care. The hospitalization days decreased by 88%. I don't know a lot of medications that can do that, but giving them access to care and knowing who to call is the way we did that. There's nothing magical about it. And the way we did that, again, is to keep them out of the emergency room. So they call us, we were able to say, okay, you're not doing well today, you're sick, let's give an extra dose, and if you start feeling worse, give us a call back. So we're able to do that by phone. And a lot of people wondered whether the patients would accept this type of care, whether they would feel comfortable talking to us through the teleconferencing, and they're all satisfied with it. And 90% felt that their privacy was maintained, 100% preferred it over travel to Gainesville. And the reason for that is that most of them don't have reliable transportation. They don't have, these are all Medicaid and CMS patients, so that they don't have reliable transportation. They also don't have the ability to just say, hey, I'm taking another day off work and I need to go every month or so until my kid is stable. So these families were often out of work when we started doing this program, and now they're able to maintain better attendance with their job. The cost benefit was that beyond the cost of the equipment and our line charges, back when we started this program in 2000, we had to use ISDN lines, and it was about $1 a minute. So even with those expensive costs, we were able to save $34,000 for these 100 children. And if we had to transport them to Gainesville for every one of their visits, because it's a medical transport, it would have cost another $37,000. So each dollar invested saved about $4. And there's a nice little picture for you saying the same thing. The second thing that we did is that we used to have a diabetes project unit. It was an ambulatory unit where children with multiple admissions for diabetes would stay in this unit. They would get psychological care and group therapy and family therapy, and it worked, but it was very expensive, so it closed. And now we have a virtual unit where a psychologist, and I have 2 minutes, so the psychologist was able to contact them 3 times a week and do virtually the same thing that they were doing in the inpatient unit, and we got about the same results. All those things. We also have trouble maintaining the education that's necessary to take care of a child with diabetes. If you imagine a very complex medical disease, you're giving a medication that could make you hyperglycemic or hypoglycemic, and we send these people home with their child, say, good luck, and and we teach them everything they need to know in one lengthy session at the beginning. We can't afford to go back and do that again, and the families often, just retention of any kind of material is poor, but now we have a child who just found out they have diabetes, and we're trying to teach them everything they need to know about diabetes. So what we have done is developed an online system for doing that education. They can access it whenever they want to, as many times as they want to. It's animated, it's cartoons, it's fun, it has the little characters for the kids, and the parents don't have to admit to us that they can't read. They can watch the cartoon, or if they can read, they can go ahead and do the text portion of it. There's also I'm going to rush through this last part. Materials enough to give nurses continuing education units, and again, this has saved time, it's saved money, it's given us more time to do other things in clinic, like manage actual management problems instead of doing the education over and over again. That's it. So now I can't really tell you about what we would love to do, but portals is the next big area to be able to manage the reams and reams of data that these kids are collecting and make some good use of it. We would like them to be able to analyze that stuff at home. That's it.
Good afternoon, everyone. My name is Dr. Peter Pappas. I'm a trauma and acute care surgeon at Health First Homes Regional Medical Center in Melbourne, Florida. And certainly it's a great honor for me to be here today. And it's also a great honor, and I feel very fortunate to be able to share this table with so many visionaries in our field when it comes to telemedicine here in Florida. It also makes my job a little easier coming after them. I'd also like to thank Representative Pigman and Representative Jones for this opportunity this afternoon, and I thank them for their leadership and their courage to bring this forward into the state of Florida and truly make a difference for our patients, which, when you think about who our patients are as physicians, we're talking about our neighbors, our relatives, our family members, the people we love and we care for and work with. So obviously this is something for all of us. I'd like to talk a little bit about what we're doing in the local level within our area in Brevard County. And first, a little bit about Health First itself. We're a 4-hospital not-for-profit system in the Space Coast of Brevard County. We're affiliated with the University of Central Florida College of Medicine, and Holmes Regional Medical Center is a level 2 trauma center, and we operate a trauma and emergency general surgery program. Brevard County itself is an interesting place. I like to think of it as all of Florida in one county. We've got retirees, astronauts, and cowboys. It is a diverse environment and a beautiful place to be, but also has its challenges when it comes to providing medical care, especially emergency medical and surgical care. We're the longest county. In Florida, we've got 70 miles of coastline. Brevard County is longer than New Jersey is wide. and also dispersed population centers. We've got the oceans to our east, we've got the swamps to our west, and also large and scattered at-risk populations. Taking care of these folks, particularly from the point of view of being the major delivery system for emergency care within our county, is certainly of interest to us. And so I'd like to add to Mr. Capistrand's earlier comment about being a force multiplier. I'd also like to add another paramilitary term, force projection, and how we can use this technology to bring our expertise out to wherever the patients may be. Telemedicine in general really is, it's a telephone with a TV. It's video conferencing for medical purposes specifically. The idea of video conferencing goes all the way back to the 1950s. Remember, Maxwell Smart used to do this and get smart. Modern advances here, of course, we're talking about high-definition video and audio technology, and also portability and durability. We want something rugged. We want something that, you know, if it gets knocked over in the trauma bay in the emergency room, that's okay. If it falls out of the fireman's truck and gets run over, hopefully that'll be okay too. But communication ultimately is key. You know, we're not talking about the robot. It's not about the robot. It's about the people you connect and the expertise that you bring to the patient's bedside to support not only that care team that's there at the bedside, but to add another layer of intensity, if you will, to the medical care of that patient. As we've seen some tremendous examples already from previous speakers, there's a lot that we can do, and we really have only scratched the surface. So specifically when it comes to communicating, of course, there are the mobile carts, and they've been there since the beginning. You can literally roll the expertise anywhere, but they are a little hard to carry around. Today, though, we do have improved access through a myriad of platforms, as previous speakers have mentioned, everything from a laptop to a tablet to a smartphone. That picture you see in the lower corner of the screen, that's an exercise we did with one of our local military facilities, where essentially we improvised a mobile cart, essentially putting a laptop with a high-definition camera, bought from Radio Shack, on with a USB port onto a laptop. And Dean Burdick, I don't know if you can recognize the face there, but that's actually Dr. Louis Pisano, the director of the UM Burn Center. So from Miami, we are getting live feed burn surgery expertise for our casualty in this exercise. So telemedicine and health first, we have, and we're fortunate and proud to say that we have one of the first tele-ICU systems in the southeastern United States. We started this program back in 2004. We're 4 hospitals across a 25-mile area, pretty much run up and down I-95 through Brevard County, 100 ICU beds, and greater than 16,000 patient interactions a year between a group of critical care trained physicians and nurses working in one core, as we call it, one command center, if you would, which is receiving real-time telemetry. It has real-time audio and video feedback from each of these ICU rooms and is interacting with the care teams on site for these patients. We're also, I'm proud to say, since 2008, also working in conjunction with the University of Miami and their tremendous program there, we've been able to join the Florida Trauma Tele Network, and I'm proud to be able to lead and help coordinate that project locally. So when it comes to developing telemedicine on a grand scale, certainly from the point of view of a trauma surgeon, I want to see this do 2 things, and certainly from the point of view of anyone involved in emergency medical or surgical care. We certainly want to expand healthcare's reach. We want this to be a force projector. And certainly, I think one program I'd like to highlight here is our e-mobile cart program through our tele-ICU, but we're also working with telepsychiatry and telestroke. And also, certainly, as trauma surgeons, as emergency physicians, we have a vested interest in the public safety and in giving back to our communities, which we, in many ways, are really there to protect. One of the reasons we get into this line of work is it will. And that's where something like the Florida Trauma Telenetwork and the SparrowNet initiative, which I help coordinate, comes into play. And then ultimately the Tactile project, which is a pilot program that we have working with various EMS agencies within our area of service for our trauma center. The e-mobile program is pretty straightforward. We wanted to see if we could take our tele-ICU and really take it to any hospital bed or emergency room bed anywhere within our 4-hospital system. We have mobile carts, which we have largely put together ourselves with the help of a vendor. And the idea here is you take the notion of what's known as a rapid response team. This is something that's come along certainly within the past 10 years, where if you have a patient that's critical in a hospital room or, say, an airway breathing circulation issue, these RRT teams will go out, and they usually are made up of ICU-trained nurses, critical care-trained nurses, and respiratory therapists, and they'll go and evaluate the patient. Now, when they go to evaluate that patient, we bring a mobile cart along and give them a connection directly back to our tele-ICU center, where there are critically trained physicians and nurses to support them. And these are typically patients who would routinely need an ICU bed. We started a pilot program back in January 2012, and over the past 20 months, we've had about 340 patients evaluated and treated, and have been able to treat patients successfully and prevent ICU admissions for 102 patients. That would make any hospital accountant happy. And it is something that certainly has been a significant plus and a significant benefit for our patients, for our hospitals, and for our tele-ICU program. In terms of public health and safety, we have what's known or lead what's known as the SparrowNet initiative. The idea here is very simple. We have about 25 trauma centers in the state of Florida. From a tactical strategic point of view when it comes to disaster preparedness, Florida south of a line between Jacksonville to Pensacola is a 400-mile sandbar. There's 2 roads out of it, there's 2 roads across it. It's not ideal if you really want to hunker down somewhere. We have hurricanes, we can have other issues as well. Being able to link together the 25 centers that make up our emergency network with the resources of the major regional and university hospitals that are behind them can be life-saving, certainly in the event of a disaster. And then also at the more local level, connect that system with our local EMS providers for mass casualty events, and you can have a very powerful tool, a force multiplier and a force projector. SparrowNet, it's not Skype, it's not Twitter, it's Sparrow. It stands for Secure, Portable, Accessible, Redundant, Reliable, Operational, Woven Network. Think about that for a second. When you think about what we've been talking about today, when you think about what we want this technology to do, that's it. We want to create a system where we're able to have, appropriate, legally acceptable means of communication that's going to work every time, help us get to our patients and help us get our patients what they need. So the goals, of course, when we talk about trauma, we talk about the golden hour, that first hour after injury where we have the greatest chance of making a difference. It's why the state trauma system exists, and also why it's one of the best anywhere in the country. Right, and what we want to do with SparrowNet is create that secure network for trauma centers, and also with tactile enhanced communication with EMS. Goals here, the principles are simple. A picture can be worth 1,000 words. Many of our speakers today have shown that clearly. We want to be able to coordinate when it comes to trauma centers communicating with one another and first responders. We want to be able to coordinate for mutual aid. We want to aid the process of triaging patients, figuring out who needs to go where. Better manage casualties, better evacuate casualties, and even in a crisis, say a major hurricane and its aftermath, still be able to have some semblance of that normal system of being able to transfer patients to major centers for care as needed. The first activation of SparrowNet at the request of the Florida Department of Health was back with Hurricane Isaac. You may recall Hurricane Isaac came up through the Straits of Florida into the Gulf and temporarily, thankfully did not actually threaten, but temporarily appeared to threaten both our Gulf Coast and the Panhandle during the time of the Republican National Convention in Tampa. We were able, certainly, to bring together all of the major Gulf Coast and Panhandle trauma centers, along with the University of Florida, the University of Miami, and also the chairman, Chief Corey Richter, of our state's Emergency Medical Services Advisory Council, plus key leadership of the Florida Department of Health. Force multiplier, force projector. We didn't need it. Thankfully, by then, all we had to do was say, hi, this is great, and we got back to work. But if we did need it, there was a need to coordinate resources, both at the level of administrative leadership and clinicians. This is the sort of tool we can use. And certainly, this is something unique to Florida, and I think something we should all be very proud of. With Tactile, it's pretty simple. Find a way to make something light and portable, tablet, smartphone, whatever, connect it to a secure network and put it out there with our paramedics, and also with our leadership for fire rescue and EMS, for triage in the field, with mass casualty management. But above all else, be able to give these folks out there who are the front lines, on the front lines, literally at the tip of the spear, an opportunity to connect back with their supporting hospitals. We have robust programs that we're developing and working on with both Chief Richter in Indian River County, Chief Jim Stables with Palm Bay Fire Rescue, and also Chief Orlando Dominguez, our head of fire rescue in Brevard County. I'm proud to say I was able to lead a small delegation up to Atlanta, where we did receive an award from the Alliance for Innovation with the city of Palm Bay. And it certainly was a big boost. Everybody got interested in it after that. And I believe that this can be a technology for EMS and for emergency services that can be as revolutionary as what CB radio was in the 50s and 60s when it started getting on ambulances and police cars and fire trucks. So in my mind, telemedicine in and of itself, no, it's not about the robot. It's about bringing people together. It's about creating a new line of communication. And this is a new road for the future, for a new era in healthcare. And I'm absolutely convinced that Florida can lead the way. Thank you all very much.
Hi, thank you. My name is Jeff Waxman. I'm the Practice Operations Director at Mobile Physician Services. And then in the next 7 minutes, I'm going to show you some holes in our healthcare delivery system here in Florida. To begin with, Mobile Physician Services is a multi-specialty house call practice. We have internal medicine, primary care, wound care, pain management, optometry, podiatry, and psychiatry servicing the greater Tampa Bay area, which includes Hernando, Pasco, Pinellas, Hillsborough, Manatee, and Sarasota counties. All of our services are house calls. We go out and we see patients in their private homes. These individuals are high utilizing members of our healthcare system. Now, at Mobile Physician Services, we use the word high utilizing. Some people use the term, as private insurance use, high risk. Hospitals call them frequent flyers. And Cindy Mann, the director for Center for Medicaid and CHIP Services, calls them super utilizers. So that's what I'm going to use for today's presentation. Real quick, in the Medicare system, 7% of Medicare beneficiaries account for 50% of Medicare spending. I want you to reference this because we're talking about the Medicaid system. In the Medicaid system, it's even worse. 5% of Medicaid beneficiaries account for 54% of Medicaid spending. If we lined up, if we had on stage here 100 Medicaid beneficiaries, and we said we're going to spend $1 million on your health care this year, the first 5 members would have over $500,000 of the dollars going just to them. This is very disproportionate. Another unique thing about this study was that they're actually able to look into the claims data of these Medicaid beneficiaries and actually found the super utilizing 1%, which accounted for 25% of Medicaid spending. With regards to the Medicaid 1%, I think it's very interesting to show here that 60% of them have 5 or more chronic conditions. So why do we have super utilizers? Why do we have this very small patient population that's chewing up the majority of our healthcare dollars? Well, it's easy. They're accessing healthcare at the most expensive points: emergency room visits and hospitalizations. The center, I apologize, the Journal of Nursing Care Quality published an article, and they said this could all be avoided if these patients had access to care coordination and access to primary care. The key word is access. The majority of these super utilizers are homebound. Per CMS guidelines, homebound means leaving your home is medically inadvisable. You require supportive devices such as a wheelchair, a walker, a Hoyer lift. Or leaving your home requires considerable and taxing effort. These are the only patients that Mobile Physician Services cares for. Combine these homebound patients who can't get out to access primary care with the physician shortage we've already heard about, few physicians participating in the Medicaid system, and even fewer of those Medicaid physicians producing house calls. It leads to a very big shortage, very large access issue. Real briefly, providing access to homebound patients creates significant cost savings. Dr. Eads' analysis of the VA's house call program showed a 24% reduction in total healthcare spending just by providing primary care access to the patient's home. The Journal of American Geriatric Society was able to demonstrate a 50% reduction in hospitalizations, again, just by sending the doctor to the patient's home. Dr. Bowling with the Virginia Commonwealth University ran a house call program, and they showed a 60% total cost of care cost savings for these entire homebound patients. So why is this guy up here talking about homebound and house call visits at a telemedicine conference, right? Well, telemedicine allows these high-utilizing homebound patients access to telemedicine services. If they were permitted to have telemedicine services, we'd be able to not only decrease total healthcare spending, but increase patient clinical outcomes. The problem is the current regulations. The originating site, for those who don't know, I mean, that's where the patient's located, must be at one of these facilities. And the originating site, one of these facilities, must be located within a health professional shortage area or outside of a metropolitan statistical area. This does us no good. The only way for a homebound patient who can't leave their home, it doesn't matter if they're 2 blocks away from here or they live in the middle of a rural part of Florida, they have to pick up the phone, call for ambulance transport, or just call 911 to be taken to their hospital just to receive the benefit of telemedicine. By that point, we've already missed the train. We've already increased the expense. So another issue we have is we need this to be statewide. Again, it doesn't matter. There are homebound patients, I guarantee you, 2 blocks away from the Mayo Clinic. It doesn't matter, again, if they're there or if they're in the middle of the rural healthcare. They can't leave their home. So we need to expand coverage for statewide access for homebound patients. In the state of Florida, we have over 679,000 homebound patients, 31,000 of which are only in those healthcare shortage areas. That means we're leaving 95.4% of these high utilizing members without service. And again, that's if they get to go to the hospital to receive telemedicine. So if we can go statewide, include the home as the originating site, not a hospital or rural clinic, and also allow for house call services, the CPT codes, to be a covered benefit. Right now, if we were to go able and do this and bill a house call at the patient's home, first of all, we'd get rejected for points 1 and 2, but then we get rejected for point number 3 of place of service of the home. At Mobile Physician Services, we actually hired a independent actuarial service that specializes in healthcare spending. And we said, hey, this is what we're currently doing. This is our model. These are the patients we're taking care of. Here's our data. What if we were able to run a small pilot program? What if we were able to go with 0.3% of homebound patients? That's not even 1%. That's 1/3 of 1% of homebound patients. Direct mail gets a better response rate. Okay? And we ran this for 36 months. We would save the system $89 million. Again, this is certified by an actuary showing our data. Again, I'm going to leave on the very last slide. We just need these 3 points. It's very simple. If you could please include them in the legislation, we would be happy to save you guys billions. My name is Jeff Waxman. Again, I'm with Mobile Physician Services. I work with homebound patients and providers that we go with homebound patients, serves homebound patients each day. And each day they ask me for help. Jeff, we need derm. Jeff, we need a pulmonologist. Jeff, we need this. I keep saying, okay, we'll try, and trying to do it on the Medicare and Medicaid fee-for-service. It's like, So I promised them that I would do everything I can to come out and try to gain your support. So please call or email me anytime. I'm willing to help. Thank you.
We'll have a brief question and answer session. Are there any questions from the audience for any of the panelists? Yes, ma'am.
Hi, Cary Pigman, Florida Hospital. Thank you all for being here today. I'm
Define telesurgery. What exactly are you thinking about?
In multiple locations and having the physician at one location so they can work on this patient here and then scrub it and go to this patient.
You may have a problem with the patients in that situation. I think certainly the robotic surgery devices that are out there, I believe actually there's only one company making them, or one major company. Certainly that entire project evolved out of the concept of trying to create remote surgical services. Certainly it's something in terms of, say, having in-surgery second opinions or surgical consultations being done remotely. That's something the late, great Jeffrey Augenstein was working on seriously at the Writer Trauma Center.
Right. I was just going to add
Right.
that there is teleurology at the University of Miami using the Da Vinci
Right.
model where some of our doctors have treated patients surgically in Orlando. So that is being done. That I don't know if you're asking, is it possible, or what was the specific about it?
Regulations, or I know we're talking about regulations for all these other things to remove barriers and breakdown. Is there anything in telesurgery that fits in with that as well?
I'm not aware of anything specifically for surgery. I think there's just the broad guidelines that we all have to follow.
It is, yeah.
And my colleague, if Scott could answer.
Well, and the other thing, that was a good response about what do you mean by telesurgery. The VA, for example, is one of the organizations that's using telemedicine for pre and post, so kind of the perioperative period. So, for example, the Miami VA, instead of having patients drive down from Orlando or drive down from West Palm Beach VA to go in cancer surgery at our cancer hospital, they do all the pre-op assessment by telemedicine, saving them that visit, and they get them out of the hospital faster and even do the post-op follow-up too. So it's not the telesurgery, but it's telemedicine that's applied to it.
Telesurgical care in general, certainly, as in teleemergency care, et cetera. Anything that certainly is a physician-patient interaction or physician, healthcare provider interaction can have a telemedicine component to it. There's no doubt about that. And certainly streamlining the pre and post surgical management certainly is of value. But remember, ultimately, every operation has its complications. Every operation has its unknowns. And you really, originally the idea of robotic surgery was for going to Mars or working on people in profoundly austere environments. I think there's a lot that gets into what the standard of care needs to be, what are the legal ramifications of an event, who is responsible if things do not go perfectly, and those things need to be worked out in advance. But technically, yes, it is possible by internet to be in Miami and operate on someone in Orlando via a Da Vinci system.
Well, there's regulations and questions or whatever. Is that being discussed along with everything else, the complications?
The beautiful thing is everything is just so new. We can start that conversation right now and find someone to support it within
One more
leadership.
question.
Each of you were governor for the day. What would you ask the President of the Senate or the Speaker of the House to do in the 2014 legislative session? One thing.
I would have that person present and garner support for Florida to be the next state to mandate reimbursement for care, whether it is in person or by telemedicine, period.
It seems like we have consensus there. So thank you very much, panelists. If you'll give us a moment, we'll release you and bring the next group up. Thank you.
As our next panel is coming up, I do want to take a few seconds. Senator Bean had to leave. We also had Representative Cummings right in the back, and we want to thank him for being here. And our Senator Arthenia Joyner, our Democratic leader designee, is also here, and we want to thank her for being here. We have a number of members that are joining us via live stream and their staffs. Senator Hayes, Senator Stargill's office, and as well as Senator Joyner's office are on the line, as well as Representative Santiago, Representative Thurston, and Representative Precourt's offices. We have representatives from Senator Gibson's office, Did I miss anyone? You're sitting back here in the back. You're supposed to be up front with the rest of us, okay? Representative Braxton is here with us, and he is committed to working with us through this process, and I appreciate him being here today as well. Are we ready?
I think we're ready.
Thank you so much.
Now we're going to take some time to hear from representatives from industries who are either impacted by telemedicine or are closely connected with the telemedicine industry. I'm going to work through these introductions a little bit quicker this time. For this segment, we'll hear from Dr. Floyd Willis. Dr. Willis is the chair of the Mayo Clinic's Department of Family Medicine and assistant professor of family medicine, Mayo Clinic College of Medicine. His interest is in dementia and in cross-cultural populations, as well as telemedicine. Next, we'll link with Linda Bowles, who will be connecting with us via video. She is a chief strategist at Cisco Systems and for the public sector healthcare operation. She's more than 20 years in the industry with experience in laboratory medicine, emergency medicine, radiology, ICU, labor and delivery, and psychiatry. Then we'll hear from Louise Damon. Louise Damon is the RN supervisor for the telehealth program at the North Florida, South Georgia Veterans Health System, HUA. She's proud to be a part of the Department of Veteran Affairs mission, which is to honor America's veterans by providing exceptional health care that improves their health and well-being. Following Louise, we'll hear from Scott Simmons. Scott is the director of telehealth at the University of Miami, and he has broad base in telehealth experience, including systems engineering, project management, program management, research, evaluation, and leadership. And he began his career in telehealth several years ago with the U.S. Space Program at the Johnson Space Center, where he was project manager for development of the telemedicine instrumentation PAC, which was NASA's first space-certified telemedicine system. And after Scott, we'll hear from Rich Rasmussen. Rich serves as vice president for membership relations for the Florida Hospital Association. One of his responsibilities in his current role is to supervise the emergency management functions for the association and work directly with the Rural Hospital Chief Information Officer and Psychiatric Service Councils of the FHA.
Good afternoon. I would like to thank Representatives Pigman and Jones for having put forth the energy to organize this conference, and I'm delighted to be here with you. My goal is to simply demonstrate for you a program that we are working with. It is not up, live, and running as of yet, but we hope it will be very soon. I guess my perspective is from three particular areas. Number one, I am a fairly busy primary care physician, and we are under a lot of pressure to try to make sure that the health care that we provide is done so in the most efficient possible fashion. We run out of time, we run out of access. We believe that telemedicine can help us significantly with that. Second perspective is, as Dr. Burdick and several others mentioned before, we originally got into this 15 years or so ago because of, and I would be remiss if we didn't specifically identify this, there's a tremendous disparities issue in this country that we will have to tackle and face as we tackle the notion of decreased access and increased cost. I believe that proper utilization of telemedicine allows us to provide care to those people in rural inner cities, those who don't traditionally have access, those who might not be able to afford access. And it is very important that as we develop these technologies, and we frequently spend a lot of time and dollars developing them on one segment of the population, it's very important that we be sure that we develop the appropriate tools, the culturally appropriate tools for all populations, because it truly is a leverage to sort of help to deliver health care to everyone. And thirdly, I speak from the perspective of a member of the Office of Population Health Management at Mayo Clinic Foundation. We work diligently to try to provide patient-centered care for the individual, but also to harness what we learn to care for populations, large groups of people, to do it through teamwork, by providing individual care to those patients, partnering with the patients. But neither of those two things can really be done like we feel they should without harnessing technology. So it's very important for us to be able to do that. Currently, I will say the board rulings, the Board of Medicine rulings here in the state of Florida really don't allow us to approach chronic disease management and even acute care using telemedicine tools as we would like. We are hoping that with upcoming discussions at the Board of Medicine and the work of our representatives through the Senate, that the landscape will change and it will allow us to open up our practices and access as many before may have described. So with that, what I'll do is take a brief moment and simply demonstrate what I hope will work, and after it, I'll explain how we plan to use it. This is a screenshot of Mayo Clinic online services. About 1 second. I believe it timed out while I was talking.
That's good security.
Yeah. Let's see if it goes in now. So what you are looking at is the Mayo Clinic web portal. And in brief, it is our patients' ability to log on, look at their medical records, look at their appointments, look at their billing information. And all of this is available at mayoclinic.org. And there is an app for everything, including this. So it's right here on my cell phone, and you can download it and you can access this information. This allows us to exchange email, secure, HIPAA-compliant information with our patients. But the thing that we aren't able to harness quite this moment is this. So if you look at appointments, can you hear me in the back? Now this, one would not find on the current version of mayoclinic.org. This is a mock screen. But if you look at appointments, what we plan to get in as soon as we can is this online visit. This is an asynchronous, so non-face-to-face interaction with a patient. And what we want to do is to be able to use it to manage those chronic diseases that are probably 30 to 40% of the healthcare dollars, 40 to 50, being eaten up by 5 to 10% of patients. So I am here to do an e-visit. There are disclaimers. One cannot put in an e-visit for I'm having a heart attack, what do I do? Or I think I'm pregnant, what do I do? This is a mock fee. I'm not sure what that fee would be, but yes, you agree to those things. And you're going to go see Dr. Willis. You may choose one of these options. There are 6,000 of these. I'm going to put in as an example, cough. Yes, I have a cough. So it's an algorithm-driven question and answer. Could be done on a touch screen. Yes, I have a cough. How long have you had it? 1 to 3 days. Yes, I had the flu. I have it all day long. Does it wake you up? Yes. So you see how this works. I won't bore you by going through the remainder of the questions, but they can be 15 questions, they can be 35 questions long. So I will answer no to the remainder of these because I want you to see the end product. Once the patient answers these questions, which they may answer from their home, from their office, from my office even, you've completed the questionnaire. It provides that report, which is essentially the same note that I would generate if they saw me, right? And you send it. And that is received in my Mayo Clinic electronic medical record. Comes right to my inbox, or perhaps to my nurse's inbox. And no. I say that, though, a reason, it's teamwork. So there may be some of these that are put through that my nurses need to address immediately. There may be some of them that really don't require my attention. They go to my nurse manager, my care manager. Some of them will come directly to me. Some of them would require prescriptions. Very difficult. I would say it probably is against the current board rules for me to prescribe anything in this manner, in this state. If I were in Minnesota, we could do it. How is it useful for us? There are a number of my patients, and I'm sure there are a number of you in this room, who have to have your cholesterol medicines adjusted or your diabetes medicines adjusted or something for which you've already spoken with the doctor. But do you really need to stop, get in your car, drive across town, speak with that doctor? Maybe it can't be done by phone because the physician needs structured information. I want to know, did you have a bad reaction to the previous medicine? Are you still smoking? There may be questions I wish to answer. So I want that structured information, and I reply, and there we've reduced a visit that was not necessary for you to come see me. Would be very, very useful if I got reimbursed for that. But quite frankly, there are a lot of people out there who are self-insured, like Mayo Clinic, or who see large numbers of Medicare patients. Okay, the reimbursement's not the best in the whole world, if no one ever told you. And we would just as soon find a way to take care of those people conveniently in their own home if they don't need to see us. Because that way I can spend a longer amount of time with those folks that do come in and keep them out of the hospital and out of the ER. Thank you very much.
Can you hear me? Can you hear me or see me? This is Linda Bowles.
Yes, we can.
Oh, you can see me?
Yes.
Oh, great. Well, good afternoon, everybody, and I would like to thank both Representative Pigman and Jones for allowing me to speak today on telemedicine and the future of telemedicine. Give me 1 second while I pull up my presentation. Can you all see my presentation now?
Yes.
Great. Well, I'd like to share with you a little bit of information and some of the new data that's out on telemedicine and care at a distance in the world. Some of the new statistics around telemedicine in the market. There's currently a report actually done by Cisco worldwide that 48 million people without electricity actually and landline internet access have a mobile phone. So we can see how the market is shifting and how we're needing to communicate with people in the future. The U.S. telehealth market is predicted to grow by 600% between now and 2017. Worldwide, probably total over $24 billion by 2016. And 89% of healthcare executives actually expect telemedicine to transform the entire U.S. healthcare system in the next decade. It's also estimated that broadband-enabled real-time video consultations could replace up to 45% of in-person visits. We are really seeing the transformation in healthcare using technology. And recently, Virtuwell actually is an online clinic offered by Health Partners in Minneapolis, is reporting that average cost per episode is half that of a traditional encounter. So you're seeing the big transformation. Cisco actually did a global, worldwide healthcare study, and we tested patient and healthcare decision makers' practices across 3 innovation concepts that I'd like to share with you today. 1 was privacy versus enhanced service. 2 was in-person visits versus video or social media. And 3 was trust and distrust in machines. So the results of this study are really one of the big things that we're seeing change the worldwide adoption of telemedicine and the shift in perception of using technology. As many of you may know, YouTube has surpassed Google as the #1 search engine. So we're seeing this big movement to the use of video. Trust in telehealth alone, over 76% of patients said they find access to care more important than physical human contact with their care provider. So you can see that the citizens and our constituents out there are demanding the use of technology and video to get what they need. Trusted information sharing, 65% of the health practitioners tested were willing to share their personal and private information, and of patients, it was 49%. We're seeing a lot more interest in security and belief in security in the system out there. And then, of course, trust in devices. We have patients, over 70% of patients that they would trust an automated device to provide a diagnosis and determine whether or not they need to see a doctor. Trust in the cloud. This is a big movement. You know, we see a lot of the health information exchanges out there and opting in, opting out in different states, you know, to provide your medical data to whomever it's needed to. We had over 74% of patients say that they are comfortable having their health records available in a cloud, assuming there is adequate security. Germany and Japan, we're actually a little bit less trusting of this cloud technology. So, you know, trust in mobile health is really, you know, where a lot of the big concerns and misperceptions exist in healthcare. But we have over 60% of patients showing an interest in receiving their health information on computers and mobile devices. So, speaking of that, you know, we're seeing the patient experience come to the patient wherever they may be. And I know I'd like to make one final point around security. One of the jobs Cisco really leads worldwide is connecting people and making sure that those are secure. Our medical grade network platform, and I know Dr. Pappas talked about secure network, and that's really of the utmost importance with high tech and HIPAA and all the regulations that exist out there. So there's no product that can say it's HIPAA compliant. It's how you set up your network and how you set up your systems to make sure that they are compliant with those regulations. Again, thank you everyone very much. And if you have any questions, I'm happy to take email. My email is lholes@cisco.com.
Nope, that's not me. Well, good afternoon, everybody, and thank you for the invitation to speak on behalf of the VA in our implementation of telehealth in healthcare. I'm a nurse by trade. My name's Louise Damon. I'm the nurse supervisor for the telehealth program. The veterans, North Florida, South Georgia, is comprised of about 120,000 patients, veterans in the North Florida, South Georgia area. We have 2 hospitals, Lake City and Gainesville. We have 11 outpatient clinics that span from Marianna, Florida to Waycross, Georgia. We have representatives and down to the villages. We have representatives in the audience, 3 of our actual living, breathing nurses that are telehealth clinical technicians. Just raise your hand so I can embarrass you for a second. So if anyone wants to, and we're just real proud to be here to share with you some of what we're implementing in telehealth. So the Veterans Administration, we have actually 827 outpatient clinics and 152 VA hospitals. We have a huge population. We're all over the country. And telemedicine trailblazer Dr. Gionola did quote that a successful telemedicine project has to make economical sense. It also must have clinical relevance. It must fill the gaps where clinical specialties are not available in remote areas, expand care, and show a cost avoidance. And I'll be showing some of these to you today. The mission of our service, of telehealth service, which is based out of Washington, D.C., and they dictate what we do, is to provide the right care in the right place at the right time through the effective, cost-effective, and appropriate use of health information and telecommunication technologies. A lot of what folks have been talking about really almost redundant in making some of my claims today and some of my presentation. So in essence, I feel like I'm preaching to the choir. So our vision beyond that, if you look at this iceberg, at the top is what the patients see, but at the bottom is what they don't see. And there's a lot that goes behind the scenes that we're all involved with in the trenches, and we have a lot of work to do. And of course, the VA has some impact, some, I would say, exemption to some of the rules that private sector does, but in essence, we do bill Medicaid and our Medicare, so we are affected by the legislation as well. We talked already about telemedicine versus telehealth, so I won't repeat that. And by the way, what about the patient? When I was in nursing school, I always asked, what does that mean, the BWATP? And it's not about technology. We've already discussed this, so I won't belabor that point. At the VA, we have 5 virtual care modalities. So we have the CVT, we have the store and forward SFT, we have the home telehealth, and we have e-consults, and we're already using secure messaging in My Healthy Vet, which is an online communication with providers and the provider team and the veteran. So let's look at CVT real quick. It's now, the VA is now recognized as one of the world leaders in this new area of healthcare. It's really not new, it's a decade old. In fact, the VA back in the late 90s started pilot programs for telehealth and started in about 2003 instituting the CVT and the SFT format. Here's some of the sample clinics that we have. One that's not there is infectious disease. That I just didn't have room for it. The red ones highlight our kind of big spenders, if you will, or big bang for the buck. The tele-rehab, tele-education, and tele-mental health. Originating site, distant site. Some examples that North Florida, South Georgia is engaged with is that down and across in Salt Lake City, the genomics clinic where we have patients that need genetic counseling, so they connect with a specialist in Salt Lake City. And at the provider site are one of our 3, or actually we have 15 telehealth clinical technicians that connect with them at the patient site. In Richmond, Virginia, we're doing some pre and post transplant services. The pre-work is done with a specialist in Gainesville, where the patient would go to the Gainesville site, or actually we did a 3-way call from Richmond to Gainesville to one of the patients for a annual visit down in St. Augustine. And transgender is something new that we're starting down in Miami. Both mental health-wise, so the psychological support as well as the endocrine support, and spinal cord injury clinic out in Tampa. All of these sites that are listed on the right are providing services to veterans all over the United States. So it's not just North Florida, South Georgia. Look at SFT, and actually a picture is not worth 1,000 words, it's worth 1,000 miles, or even more. So SFT, we kind of talked about that. We're also doing a lot of wound therapy through SFT as well as CVT. Home telehealth, we have clinical care managers with the home telehealth program. So we're connecting the patients to home devices, and the practitioner can determine what healthcare needs are needed. Progress, and if I may just interrupt myself for a second, go ahead and if you look at my name on the agenda, put a dot between Louise and Damon and put @va.gov, and you can email me and I'd be happy to send you this presentation because there's a lot, unfortunately, I won't cover. Store and forward, as you see the upward trend, so over the years, on the left is 2007, and we're just going up with all our programs. Outcome data for home telehealth, 2009, 29% reduction in admissions. There's proof, it works. The key is access to care, as others have said. In fiscal 12, nearly 500,000 veterans received care remotely, and it's anticipated that 600,000 vets in 2013 will, and the VA has spent $500 million on telehealth expansion projects last year. The difference between VA and the public sector, we kind of already, I think, know what that really is, and why the private sector lags behind telehealth. Telehealth has helped reduce veteran hospital admissions. There's no question about it. So these technologies are helping us create a care without walls. A system without walls is a virtual system of care. It's how the VA is doing business, and I want everyone else to get on board with it because there is definite value to it. And as you see, it's a puzzle, and we're starting to put pieces together. I'd be happy to entertain any emails with questions about a lot of the advances that the VA is doing. Very proud of it. It is we have a lot of work to do, but I think it can be done. Thank you.
Is everybody still with us? And I was going to start off with a joke about whether it was a worse position to be in, standing between a group of physicians and a free lunch, or a group of politicians in a press conference. But sometimes the jokes write themselves. I was not surprised to find out that the Miami VA was going to be the place where they were starting the transgender telehealth. So there's a brief bio at the beginning. I've been doing this telehealth or telemedicine stuff for about 20 years, starting with the space program and got involved in rural telehealth at East Carolina University, and now been with the University of Miami for about 6 years. And I just wanted to make a few observations and a comment. I think we're really doing ourselves a disservice, and Gary mentioned this up front, if we're going to get into an academic debate about what telemedicine and telehealth and e-health and connected health and what those things are. It's all semantics. I mean, we're really talking about using technology to provide health services at a distance, right? So I think we should stop differentiating between those things. So I just want to leave with a couple of points. First is the vast majority of medicine encounters are cognitive. Right, and a colleague of ours from Stanford estimates that somewhere around 85% of medicine is cognitive. So in other words, that physicians are processing information. That information can be actual physical observation of a physical exam, it could be interpretation of electrocardiogram, could be look at images, but that a vast majority of it is cognitive, or it's in the brain. So what the resource is physicians' brains or healthcare providers' brains, right? But the problem is that this is a finite and I would say dwindling resource, right? So it's limited. So it's either because it's scarce or because it's geographically maldistributed, right? Technology is really, really good at collecting and moving information, which is what this cognitive stuff is about. So the promise
is that we can use technology to be able to more efficiently distribute this resource. So it's really our physicians' brains or their expert opinions is really what we want to be able to distribute, and technology does this very well. So that's the fundamental, I would say that's the fundamental theorem of telehealth, is that we can more efficiently distribute this limited resource. And that's really because we're talking about having a larger insured population because of the Affordable Care Act. We're talking about smaller amounts of specialists and providers and an aging population. So that's a bigger demand and a supply that's not getting any bigger, and it might be getting smaller. So we need to be more efficient in the way we're delivering health services. And telehealth is only one part of the solution, of what you might call a digital health ecosystem. So it's, you could say it's electronic health records, telehealth, imaging systems. So these are the PACS, picture archiving communication systems, laboratory, point of care devices. It's all part of a continuum. So I would call it a digital health ecosystem. And we really see this, another way to look at it might be health information and communications technology really enables a complete redefinition of what the point of care is. Because traditionally, and our reimbursement system, some people have alluded to, is built this way. Our education system is built based on this, I think, outdated vision of what the point of care is. Technology enables care to be provided anywhere. So instead of a patient physically coming to a wonderful facility like this, or our University of Miami facilities, or a clinic or somewhere, the doctor or the medical expert can now virtually travel anywhere, whether that's a mobile phone, whether that's the home, as some folks have mentioned, whether it's the school, and Dr. Burdick mentioned that we're doing a 9-school pilot, Miami-Dade schools, or whether it's the workplace. And really what we're doing for Royal Caribbean and Carnival Cruises right now is workplace healthcare. These crew members that we're serving are all on-site working. Now, it happens to be incredibly more expensive and less efficient to evacuate a crew member from a ship, but that's also think of all the inefficiencies in the healthcare system that our employers are undergoing by time away from work, time spent in an office waiting to go from one waiting room to another waiting room. So think about that 15 minutes with the physician is actually 4+ hours away from work. So there's a very strong efficiency and productivity element to this too, excuse me. So I think there are several opportunities and challenges in able to use technology to improve healthcare in the state of Florida. So obviously the big one is access, right? Improving access, so both urban and rural underserved communities. The access is not there, and that's one of the ways that we can more efficiently do this, that you can't be at two places at the same time, but you can virtually, right? And that's what a lot of it's been about. But I definitely think there's an opportunity in terms of work site and corporate telehealth productivity, providing care in the schools and other points of convenience. Because if you think about taking a child to see either a pediatrician or pediatric specialist, the child isn't, unless they're over 16, the child isn't taking them. Can I have my water real quick? Thanks. Not only are they leaving school and not in the classroom, but also their parent or guardian or cousin is taking time off from work and spending time with them too. So that's incredibly inefficient. Something that's real near and dear to my heart, and I was glad to hear someone mention it before, is using telehealth in disaster relief, humanitarian assistance and disaster response. I think that's a huge thing in the state of Florida. But the challenges, a number of people have mentioned, and I don't want to reiterate too much, just to emphasize maybe more than reiterate. Regulation is obviously a challenge. We've talked about reimbursement in that, and I think what seems to be a common thread is we're not talking about adding to the stack of regulations. I think we're talking about trying to reduce the barriers to telehealth. So whether that's, and I think it was Gary up front that very astutely said that we would just want it to be treated as healthcare. If you treat telehealth as equivalent, substantially equivalent, like the FDA might say, to face-to-face care, a lot of these regulatory barriers are gone, right? So I think that's a really important thing. One thing that